Acute stroke for ACLS. Stroke is a condition in which normal blood flow to the brain is interrupted. Strokes can occur in two variations, ischemic and hemorrhagic. Acute ischemic stroke accounts for 85% of a stroke, which is more common than hemorrhagic stroke. In acute ischemic stroke, interruption of a blood circulation, occlusion of a cerebral artery, brain partially deprived of oxygen and nutrients, main cause atherosclerosis and atrial fibrillation, caused by trauma made of fibrin. While in hemorrhagic stroke, which account for 15% of strokes, there is vessel rupture of the wall of a cerebral artery, resulting in bleeding into the brain. Main cause high blood pressure. In general, the symptoms of ischemic and hemorrhagic strokes are similar. However, the treatment are very different. Symptoms and signs of a stroke: sudden numbness or weakness in the face, arm, or leg, especially on one side of the body. Confusion or trouble speaking or understanding speech. Sudden trouble seeing in one or both eyes. Sudden trouble walking, dizziness, or problems with balance. Sudden severe headache with no known cause. If any of the following symptoms, signs appear, suddenly call 911 right away. After activate emergency response, support ABCs, give oxygen if needed if the saturation less than 94. Pre-hospital stroke assessment. Establish time of symptom onset by asking the patient when they were last normal. Triage to stroke center. Alert hospital. Consider direct transfer to CT scan. Check glucose if possible. Regarding a pre-hospital stroke assessment, we have FAST, which is for facial drop, arm drift, speech abnormal. Facial drop by asking the patient to smile and looking if there is any symmetry. The details here on facial drop: look, is there any angle deviation, flattening of nasolabial fold, ability to close eye, preserved wrinkles. Then ask the patient regarding arm drift by asking the patient to close eyes and extend both arms, looking for any drift, or from the beginning, patient will not be able to elevate his arm. Speech: you can give a patient sentence, looking for any dysarthria. If any one of these three signs is abnormal, the probability of a stroke is 72%. Then, when the patient reach ER, immediate general assessment and stabilization. Again, assess ABCs, vital signs, provide oxygen if hypoxemic, IV access and lab assessment, check a glucose, treat if indicated, neurological screening assessment, activate stroke team, order emergency CT scan or MRI, obtain 12-lead ECG. This should be obtained within 10 minutes. Immediate neurologic assessment by stroke team. Review patient history. Establish time of symptom onset. Double check regarding when was the last seen normal. Perform neurological examination, but this time we should to do NIH scale. This should be done within 25 minutes. HIT CT either will show hemorrhage or no hemorrhage. If no hemorrhage, the patient probable to have acute ischemic stroke, then we will consider is he candidate for fibrinolytic therapy or not. HIT CT and report of HIT CT should be done within 45 minutes. After that, review risk and benefit with patient and family regarding fibrinolytic therapy. If acceptable, give IV TBA and be sure no antiplatelets or anticoagulation should be given after IV TBA in the last 24 hours. Patient then should be admitted to ICU or be in the emergency. Aggressive monitor for blood pressure and a neurological examination. But if the HIT CT showed any hemorrhage, patient should be evaluated by neurosurgery and neurology, and hemorrhage pathway should be started. If the patient not candidate for fibrinolytic therapy, either the patient presented after 4.5 hours or there is contraindication for giving IV TBA, we will start secondary stroke prevention like administer aspirin. This is an example of HIT CT plain axial view that showed hypodense area, which is well defined, indicates that this is more than 3 hours old. This patient not candidate for fibrinolytic. While this scan showed wide area hyperdensity in the left frontal lobe, that's mean intracerebral hemorrhage. Again, this patient not candidate for fibrinolytic therapy. This HIT CT showed acute subarachnoid hemorrhage. As we see, there is hyperdensity and multiple areas of blood vessels in ventricles. Regarding the indication of fibrinolytic therapy, it's very important to know in IH score that looking for stroke severity, usually we are giving IV TBA if the stroke scale from 5 to 25, not given in the minor stroke or severe stroke. Indication for fibrinolytic therapy: symptoms onset within the last 3 hours, 18 years or older, ischemic stroke with a neurologic deficit, and if blood pressure systolic less than 185 and diastolic less than 110. But there is contraindication that should be taken seriously. If there is any head trauma in the last 3 months, stroke history in the last 3 months, subarachnoid hemorrhage, previous ICH, active bleeding, heparin in the last 48 hours, elevated INR, especially in a patient who is taking anticoagulation like warfarin, hypoglycemia, very large brain infarction, especially if it's count more than 1/3. Platelets, if it's less than 100,000. Again, we have some relative exclusion for giving IV TBA, like very minor resolving symptoms, seizure, surgery or trauma in last 14 days, major hemorrhage in last 21 days, myocardial infarction in the last 3 months, arterial puncture in the last 7 days. If a blood pressure high and the patient candidate for fibrinolytic, blood pressure more than 220 over 120, should give labetalol to reach the target of a blood pressure 185 over 110 to give the IV TBA. But if the patient not candidate for fibrinolytic therapy, we should keep the blood pressure less than this target. So if reaching more than 220 over 120, again labetalol should be given. If a blood pressure remain between 220 to 180 and diastolic between 120 and 110, patient candidate for IVTBA, we will give the patient to reach our target. If the blood pressure remain high, the patient will not receive IVTBA. But if the patient not candidate for IVTBA, only acute therapy if there is hypertensive emergency. Otherwise, we will keep the blood pressure in the higher side. It's very important to know after stroke, the patient should be put on seizure monitoring to start anticonvulsant if it's indicated, to correct any blood abnormalities, electrolyte, osmolality, and proper glycemic and blood pressure control. Give thiamine if malnourished or alcoholic. Give osmotherapy as needed for monitor intracranial high blood pressure. Avoid hypotonic saline. Avoid excessive fluid. Keep temperature normalized and start nutritional support after. Be sure that the patient able to take orally or you can insert NGT. Don't forget physical therapy. Thank you.